just going to be the talk through of how to do a patient assessment and kind of the rationale behind why you do it. We'll go into actually doing the patient assessment, and then I will demonstrate how to do a passable patient assessment for your NREMT psychomotor. But this one, just want to talk through it. So we have our mannequin stand here, but before we even talk about our mannequin, what we want to do is when we walk into a scene, we want to look it over. The very first thing, and somebody always fails to do this, I promise you, almost every test we have somebody that doesn't say it right at the first thing that they walk in the door. They may end up picking it up later, and as long as you say it, we do have to give you points on it. So number one, first and foremost, BSI is my scene safe. We do try and have gloves in the room for you, so you have that trigger, but if you don't look at them, just make sure that you, even in your scenarios, BSI is my scene safe. The first portion of any patient assessment is assessing your scene. So safety, making sure that you have yourself safe, making sure that your scene is safe to enter, your number one priority. If you get hurt, you can't help them. The next thing is your mechanism of injury or your nature of illness. Obviously, if it's a trauma, you're going to go with mechanism of injury. If it's a medical, you're going to go with your nature of illness. This is kind of determining why your patient has called you just by looking at the scene. Your mechanism of injury on a car crash is the car crash itself. Your nature of illness, if you walk in and your patient is breathing really heavy, breathing really hard, it's more than likely going to be respiratory in nature. The next thing is number of patients. This is really important. Even on a medical scene, if you have more than one patient, it could be possible that you've got a communicable disease that you need to protect yourself from with extra PPE, putting on a mask, putting on a gown even, or if you've got several people exhibiting symptoms, you may have a carbon monoxide leak, you may have some sort of gas exposure, some sort of organophosphate exposure that you need to protect yourself from, or remove your patients immediately from the scene. So don't think that just because it's medical, that's not important. So make sure that you're assessing for your number of patients. The next thing is, do I need additional help? If you're ALS, you might need air support. If you're EMT BLS level, you might need to consider ALS. You can always cancel them, especially if you're out in one of these rural services. It might take them a while to get to you. It's better to put them on standby, let them know that you might need help, especially with that air support. They have to do checks before they can take off. So putting them on standby, making sure that you have them at the ready, and then canceling them later is always the better option versus realizing, oh no, I need them, and not having them available. The last portion is considering Cspine. It doesn't matter if this is supposed to be a medical call, shortness of breath, etc. Your patient could have fallen. He could have gotten short of breath, passed out, and hit the floor. You want to make sure that you take all the precautions necessary based on how your patient's presenting. Our patient here is in the bed. Probably does not need C-spine, but we still need to make sure that we rule that out. When you're doing these psychomotor exams, more verbalization is always better. So make sure that you're running through that. If you have a thought run through your head, go ahead and verbalize it. Make sure that you're getting the points that you deserve for the thought processes that you have. Once you get through C-spine, we've pretty much gone through the scene size up, and we're going to move into our primary assessment. The very first thing we're going to do is a general impression of our patient. A lot of times this is going to be based on your dispatch information plus what you're seeing. In our scenarios, all the time, you're not going to see all that initial information, so you can ask for it. Our patient here is actually, we're going to say, is a 82-year-old male who is complaining of shortness of breath. So my general impression, I have an 82-year-old male complaining of shortness of breath who is sitting up in bed, and then anything else, do I see rapid breathing? Do I notice any cyanosis? Those sorts of things. If that's evident because of moulage, make sure you go ahead and state that as well. The next thing, you're going to check for alertness using that AVPU scale. The easiest way to determine alertness in your patient is to talk to them. So, hi sir, my name's Alicia. I'm with the ambulance. What can I help you with today? Or why did you call the ambulance today? If my patient talks back to me, I know they're alert. If they're looking around paying attention before I even talk to them, they're watching me approach them, I know they're alert. If it takes me talking to them for them to open their eyes and talk to me, then they're verbal. If I have to sternum rub them, if I have to pinch their nail bed, then they're responsive to pain. If I can't get them to talk to me even with a painful response, then they're unresponsive. Generally with that question, I'm also going to get their chief complaint, the whole reason that I'm there. It may not be what dispatch says it is, and the obvious problem that they're having may not be the same as their chief complaint. He may be having obvious trouble breathing. His chief complaint may be chest pain. They're not exactly the same thing. Once I determine his chief complaint, then I'm going to go into assessing for life threats. Life threats are anything that revolve around airway, breathing, or circulation. ABCs. So I'll start with airway. First and foremost, I want to make sure that it's open. If he's talking to me, I know my airway is open. If he's confused, not doing well, and I want to just verify, I can always ask him just, hey, do you mind opening your mouth for me just so I can take a look? Then I verify that there's no loose, broken teeth, that his dentures are in and fitted properly, that there's no secretions, vomitus that I need to suction out, no mucus. But even somebody that's only alert to verbal, very, very confused, not really with it, may follow commands with you. So go ahead and have them open that mouth and you can take a look. The other thing with airway is, can they maintain it themselves? If they're alert, if they're at least at verbal, chances are they can probably maintain it themselves, and I don't need to insert an airway adjunct. With painful stimuli or with unresponsive, I'm going to need to insert an airway adjunct. With painful, if they're still alert to painful, I'm probably going to want to insert an NPA, so through the nose. If they're unresponsive completely, I can see if they'll take an oral adjunct, and I would want to insert it at this point. The next thing I'm going to look for is breathing. I don't just want to know if they're breathing, I want to know how they're breathing. So first and foremost, how is my patient breathing? What is the rate? Is the chest rise equal? Are the breaths deep enough? Are they adequate? Then we'll move on to circulation. First and foremost, does my patient have a pulse? What is its quality? Is it rapid? Is it slow? Is it normal? Is it regular or irregular? Is it strong, abnormally strong? Is it weak or is it regular? So it's not just asking if there is a pulse, it's getting more information about that pulse as well. You want to look around for any major bleeding that you need to control right away to make sure that your patient stays alive. And then as you're also checking for a pulse, you're going to look at skin color, temperature, and texture. The earliest sign of shock is not a low blood pressure. The earliest sign of shock is actually pale, cool, clammy skin. So if your patient is pale, cool, and clammy, no matter what their blood pressure is, they're showing early signs of shock, and we need to take care of that by putting a blanket on them, keeping them warm, giving them oxygen. With breathing, if they're breathing faster than 30 times a minute or slower than 10 times a minute, we need to make sure that we're putting oxygen on them. If they're complaining of shortness of breath at all, we need to put oxygen on them. If they are pale, cool, and clammy, we need to put oxygen on them. High flow O2 is always the way to go. With any life threats, any problems with A, B, or C, they get high flow O2. If they can maintain their airway by themselves relatively, and they're taking adequate ventilations, you can go ahead and just put on a non-rebreather mask at 10 to 15 liters per minute. Pick one of those numbers. You can't put them on a range. Generally, our rule is go big or go home, but make sure that you're doing what's right for your patient. If they're not breathing adequately, they're breathing really shallow, they're breathing really slow and deep, then you're going to have to bag them to make sure that they're getting enough oxygen. After you get through A, B, C, you need to make a transport decision. If they have a problem with A, B, or C, anything wrong with A, B, or C, they are considered a critical patient and they will need to be transported immediately. If there is not a problem with A, B, or C, you might be able to stay on the scene and assess them a little bit more. Know for The purposes of NREMT testing, they are not going to give you a patient that is not critical. So at this point, you should be transporting your patient. Make sure you're paying attention to that. The next thing that we're going to go into while we're already transporting our patient is the history. We're going to go into the OPQRST. You can utilize this with any patient that is at least verbally responsive, that can talk back and forth to you. If your patient's not verbally responsive and you have a bystander, ask the bystander, ask the family member, but you should be getting a history. OPQRST works best with painful conditions, but it can be modified for somebody that's short of breath as well. So our patient is short of breath. So, hey, can you tell me, how did this begin? What's the onset of this? Your P is your palliation or provocation. Don't ask your patient what their palliation or provocation is. They don't understand what that means. So ask them one question at a time. Hey, is there anything that makes your shortness of breath better? Let them answer. Is there anything that makes your shortness of breath worse? Let them answer. Your Q is your quality. Don't ask them what the quality of their shortness of breath feels like. Ask them what it feels like. Can you describe it to me? What does it feel like to you? R is radiation. With this, say you're probably not going to have pain with your shortness of breath, but if you do, does it go anywhere else? Or if it's tight, does that tightness go anywhere else? Does it go up into your arm? Does it go up into your neck? Do you feel like you're not able to take in enough breath all the way up to your mouth, or is it just in your chest? S is severity. You can modify this with shortness of breath as well. 0 being, you can breathe just fine. 10 is you're absolutely suffocating. Somebody's holding a pillow over your face. You feel like you're going to die. Can you rate that for me? Even though that's not a real viable scale, as you start treating them, they're going to use that first number as a reference point. And if you treat them and they give you a number that's improved or a number that's worse, you at least have some sort of reference for yes, they're getting better, or no, they're getting worse. And then T is time. Time. How bad or how long have they been at that number? When they give you a severity of 7, how long have you been at a 7? And did you start at a 7 or did you gradually get to a 7? And then you'll go into your sample. S is other signs and symptoms. What I like to do myself is this is where I ask for my pertinent negatives, the pertinent positives. So things that either point me to a condition or point me away from a condition. And I do basically a verbal head to toe in my patients that are medical. So I start out at the head. Are you having any headache? Any blurry or double vision? And he's already having shortness of breath, so I don't have to ask that, but are you having any nausea? Are you having any chest pain? Are you having any abdominal pain? Any diarrhea? No? Any numbness or tingling in your hands or feet? And then I basically just ask any associated signs or symptoms that could be with all of the conditions that could cause shortness of breath. A is allergies. Are you allergic to any medications? Are you allergic to any foods? Do you have any other allergies that I need to know about? Make sure that you break them down into categories because sometimes people forget. Medications, same thing. Do you take any medications on a daily basis? Are there any medications that you're supposed to be taking on a daily basis? How about vitamins? How about over-the-counter medications that are not prescribed by a doctor? And then P is your past medical history. Do you have any past medical history? That's an okay question to start with. But then based on the medications that they've given you, which you will learn over time what they're for, you can ask some more questions. Or you can say, do you take any medications and what is that medication for? And that will help you get your past medical history as well. Other things to ask, hey, do you have diabetes? Do you have high blood pressure? Do you have high cholesterol? You can just ask them specific questions because sometimes, again, people forget. They've had this condition for 10 years, they take a medication every day, they really don't think about it anymore. L is your last oral intake. And just ask them, hey, when's the last time you had something to eat or drink? It doesn't need to be absolutely specific, but if you can get a general ballpark, that's very helpful. E is events leading up to. So was there anything that you were doing particularly when this started? Kind of describe to me what was going on when this started. Once you get past your history, then you're going to go into your secondary. This is going to change for every patient based on what their complaint is. If he's complaining of shortness of breath, I'm going to evaluate every system that could cause shortness of breath. So I'm going to listen to his lung sounds. I'm going to check a pulse again and make sure that nothing has changed there. Check for regularity, because the cardiovascular system is very intricately entwined with the respiratory system, so it's very likely that something there could have caused a problem. With shortness of breath, I'm going to check ankles to make sure he's not backing up fluid overload, and he has fluid in his lungs. I'll check that. I would check a temperature, make sure he doesn't have pneumonia. Of course, I could rule that out with listening to breath sounds as well, but just to make sure I'm covering my bases, I'm going to go ahead and check a temperature as well. Then I'm going to go ahead and take vitals. I'm going to get an O2 saturation. I'm going to take a blood pressure. I've already got a temperature. I'm going to take an accurate pulse rate. I'm going to take an accurate respiratory rate. I could throw him on the monitor and get an EKG if that's within my scope of practice where I'm practicing. The next thing I'm going to do is, based on his condition, when and how do I reassess? Because this is a critical patient, I'm going to reassess every 5 minutes to make sure that there's no significant change in his condition. If there is, I start all the way back over at A and run through the entire assessment again. Typically, don't have to go all the way through history because your sample probably not going to change. OPQRST, you may have to go back through that to make sure that there have been no significant changes in those questions. And then finally, giving a report to either the incoming ALS unit, the helicopter, or the hospital as you arrive there. So, hey you, this is me. I'm coming in with this patient from this area. This is their chief complaint. This is how I found them, including original vitals. This is what I did to treat them. This is how those treatments changed their condition. These are current vitals now. I'm this far out. Do you have any questions for me? And that's essentially a quick walkthrough of how to perform a patient assessment medical.